Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Well, welcome everyone to another episode of The Pursuit of Health. I'm your host, Rainer Schur. And joining me back on the show today is Colleen Smith and Jared Rhodes. Welcome back.
Hello.
Thanks, Ray.
So what we've been doing the last few episodes is mostly talking about how to change healthcare through policy change and these deeper kind of cultural changes. And while we think that those are crucial to changing healthcare in the long run, they're also slow and might leave you thinking like, well, isn't there anything we can do right now? And there certainly is, right? There's all sorts of ways that business people and entrepreneurs can already change the healthcare system with new technologies and business models. This other way of changing healthcare, you could call it disruption, is one that we haven't spoken about as a distinct way of changing healthcare, but one that's certainly worth looking into, and especially how it relates to those other kinds of ways of changing the healthcare system. And with that, let's just get into some definitions. So, like, how should we think about what it means to disrupt healthcare?
So I think there are a variety of ways that healthcare has been disrupted over the last maybe really 5 years or so. I think one big way has been telemedicine, which kind of began to become something that was sort of accepted to use because it was finally being paid for by Medicare and Medicaid during COVID when we kind of had to move a lot of things virtual. And then with the use of telemedicine and this great uptick in the use of telemedicine, everyone began to realize how much more convenient that made so many aspects of our care. And there's just no way to get rid of it now because it has made everything so much better and easier. And then, some other things that have come up that have disrupted healthcare are things like cost plus drugs that Mark Cuban has started. He's kind of come in and started to make deals with employers and with pharmaceutical companies, cutting out middlemen, cutting out pharmacy benefit managers, and finding ways to offer medications at much more reasonable prices to the consumer, the patient. And it's really kind of shed a light on some of the kind of manipulations that have been going on in the background with the pharmacy benefit managers and pharmaceutical companies that have really led to this increasing high prices of drugs that we've been dealing with in the US for years before.
I'll chime in from maybe a different angle, which is just to think about like what does it even mean to be disruptive or to have a disruption. I mean, I think of it as something that like really introduces a new option, like a fundamentally new option in some way, not just like, oh, a better version of something that already exists, right? So if I start an insurance company and I'm offering basically the same plan that some other insurance company offers, but through some, I don't know, through some like efficiency method, I've managed to, make the price like 5% cheaper or something. I mean, that's nice. That's good competition at work and everything, but it's like I wouldn't consider that like disruption exactly. And so, same thing in just any other area of healthcare. Like an incremental improvement, that's all good, but it's not like a disruption. I think a disruption is really something that causes you to some person in the system, whether that's the patient or physicians or other people that are involved, somebody to really act differently, maybe be able to make a choice or take an action that they haven't previously been able to. I think those are unfortunately kind of few and far between in healthcare. I wish there were more of them. And maybe it's an interesting question to like ask why we don't see more of it and that sort of thing. Maybe we can get into that today. But that's kind of what I think about when I think of a disruption, like something that really changes the way that the options that are in front of you and allows you to do something very different than what your previous like menu of options were.
I certainly think that changing whatever environment or system a particular disruption is occurring should be part of the way that we think of disruption or disruptive technologies or business models. But I take a slightly wider perspective on it. The way that I think about it is that we should also include things that have the intent to disrupt whatever market that we're talking about. Because very often you'll have technology and ideas that are disruptive or potentially disruptive, but haven't caught on yet, right? There's all sorts of examples of people coming up with ideas and new technologies that simply there was no business model yet to carry it out. But it shows that there's like an intellectual perspective to disruption as well, that you're looking at the system as it is and thinking about how can I fundamentally change it and change it for the better. And of course, lots of ideas don't end up changing the system, but it's that kind of mentality of like, okay, let's change things and let's like have a different way of looking at things, which then the new kind of technology and business model embody. And I think that's important because it's like you said, Jared, it's not simply tinkering here or there, and I think it's a wider kind of intellectual project that you're engaged in, which then brings together that kind of intellectual input with the actual financing and technological implementation to make it happen. And I think a kind of good example of that kind of mentality is someone like Mark Cuban, right? Who views disrupting healthcare not simply as like some kind of unique business venture, but like he wants to disrupt healthcare, right? Like he has some need to shake things up, which I think is a healthy kind of attitude. But what I would like to turn to next is what's his kind of theory of disruption? How's he viewing what is needed to disrupt the system? And a kind of theory of disruption also presumes a theory of the default. Like, what's the kind of default that calls for disruption within the current healthcare system? How do you guys think that he's thinking about that?
My sense is that he sees one of the main issues of our healthcare system as being an issue of power and this sort of entrenched power, uh, groups that have power that are beginning to use their power rather than for the good, but really like for the good of patients or whatever, but actually in some sort of nefarious way to kind of continue to bolster themselves at the expense of patients. And so his view, what it seems to me, his view of disruption is kind of to disrupt those power channels, to kind of break up the what seem like monopolies. And I think there is something to that. There are kind of powerful groups in the healthcare space that have been given that power by the kind of regulatory state that we're in. And I think some of the disruption that he does also serves to elucidate some of the real issues that we're dealing with in our healthcare space. I don't know. What do you think is Mark Cuban's view of disruption?
I think that definitely part of his view, which I think is correct, is that the current system is very opaque and very complex, and that all sorts of vested interests benefit from that, right? Where the lack of transparency over prices, the complexity creates space for people to interject themselves where they either don't provide value or the value that they do provide is kind of like a mixed bag, like they provide value some of the time, but not all of the time. Or it's just not clear what kind of value they actually do provide. And his focus on PBMs is one of those things where if you looked at PBMs in the past, like, oh yeah, like they clearly did seem to have some kind of value, but now they've evolved over time, and now it's like harder to say. And in certain cases, you could say like, well, they're not providing real value. So I think he's right to then want to challenge those things by trying to offer a service that makes things the opposite of opaque and complex, which is transparent and simple. But I think where he might go wrong is assuming that those are things that the powers that be, that the vested interests not only maintain but created. I think you need to go a little bit deeper to actually understand, well, why is the system opaque and so complex to begin with?
One thing I would say is that there are like certain areas in healthcare where you can disrupt with a new like business model. There's enough room that you can get in there and sort of offer a different approach that maybe works differently. And I think I would categorize cost plus drugs as one of those examples. But I would also hasten to say, like, you can't just go around all of healthcare in doing that. There's a lot of parts of healthcare that are sort of locked down and just aren't open to that kind of disruption. So like, kudos to him to like for like, finding another, a part of that is sort of susceptible to it, and then obviously for all the hard work of like actually making the thing happen. There's a business component to it, but then there's also like the policy component to it. And there are times where, maybe there are some opportunities here and there where in healthcare where just a new business model can be the disrupting thing. Other times you probably need policy to make the change first, and then that opens up the sort of freedom for business to step in and offer the new models. There's deeper things to point out too about just sort of changing the mindset of patients and so on and so forth.
One example kind of what Jared is talking about is direct primary care, which is this model of doctors offering healthcare completely outside of the insurance industry. They don't accept insurance, Medicare, Medicaid, any of it. This kind of model does have the potential to really be disruptive, but it hasn't been especially disruptive. And kind of Jared, you were mentioning that so many things are locked down in medicine, and I think two reasons that direct primary care hasn't been so disruptive. One reason is that doctors who are in direct primary care, if you're in that situation, you have to opt out of Medicare and Medicaid, and so now you really are not allowed in any way to participate in hospital medicine because all hospitals have to accept Medicare and Medicaid essentially to survive. And so there's this system where doctors either have to choose one route or the other. And so if you're in direct primary care, you're not an educator anymore, you're not working with residents, you can't spend time in a hospital, you really have to pick one thing or the other. And so that's a huge limiting factor on doctors. And then I think the other thing is we were talking a little bit about mindset and kind of culture. A lot of doctors have gone to direct primary care, not so much to be a disruptor, but because they're looking for a model of medicine that feels just kind of better for them, that they can have a deeper relationship with their patients and get out of the kind of rat race feeling of medicine that does accept insurance and Medicare and Medicaid. And so for them, it's not really about disrupting, it's more about trying to create a better doctor patient relationship. And because they don't see it that way culturally, it just it hasn't taken off in the same way that Mark Cuban's cost plus drugs that he has specifically said is about disrupting medicine has taken off.
Yeah, I think a potential blind spot from Mark Cuban is precisely that he is a business person, and he might take for granted that, like, well, yeah, prices should be fair, like deal should be fair for both parties, and he's just like surprised that like is not happening in all sorts of areas in healthcare. But there's a reason for that. The reason why healthcare is so opaque when it comes to things like prices is precisely because health insurance pays for most of healthcare. And that didn't come about by accident. It came about because all sorts of other innovative models for funding and financing the delivery of healthcare were squashed by the American Medical Association. We covered that in our last episode, right? So there was a time where like different models and kind of disruption was occurring, but it was shut down, and it was shut down for a particular reason is that there was a concern that we don't want healthcare and medicine to be too commercial, right? We don't want it to be a business. And so I see the opacity as kind of like a necessary feature of not wanting healthcare to be shoppable, right? Where if you bring in a third party payer, well, then by definition, the interaction is not going to be direct, right? And if we look at complexity, I think the complexity is caused by a slightly different thing, which is that there has always been resistance to comprehensive healthcare reform, right? There's been pushback against complete national health insurance program, but on the other hand, people still want like a semblance of a market, right? And what that leads to is that any kind of reform is a patchwork. And then you get patchwork on top of patchwork on top of patchwork. Well, that creates complexity, but that's again caused by this kind of tension and ambivalence that, well, we don't want a complete free market, but we don't want a completely nationalized, socialized healthcare system either, where the government controls everything. So what do you get then? Well, then you get like this patchwork system where you have these different programs, these different rules, these different regulations, depending on the patient, the buyer, the provider, the insurer. And yeah, then that kind of complexity, if you're a really big corporation, you can take advantage of that. But it's not like the big corporations created that. That's the system that they're in. I think for that to change, need to do more than just taking on the powers that be, right? That like might sound motivating and exciting, but you need something positive, and you need to have a broader rethinking of the interests of patients and providers, where they don't just want things to be less complex and less opaque, right? They want things to be simpler and more transparent so that they can shop for healthcare. But again, that's something which almost by design has been designed out of the system. And I think the main reason why Mark Cuban has been so successful in the space of pharmaceuticals is precisely because it's the one area of healthcare that is more like an actual shopping experience where people do accept that, right? But then when it comes to things like dealing with your doctor, is that, well, people don't want to think of that as shopping. And so I think you would really have to take that on in order to actually be disruptive in healthcare.
To your last point, it's maybe not a surprise that that this particular area is a candidate for some of this kind of disruption, and that it fits. There's a cash pay element to pharmaceuticals. I mean, lots of different plans out there. Some people have big drug plan coverage, but others don't. But there is a sort of like you were saying, there's like an element of some cash pay there and some shopping still, at least a little bit. And there's also the other kind of interesting thing to point out. When you're talking about generics, you're now in the realm of something that's like that an economist would call a commodity, and so that does simplify things a little bit. Now you're not talking about personal relationships with doctors and such. You're not talking about like limiting people's choice of networks and all that. Like a lot of these other issues would get very very messy really quickly. But at least with by tackling something like drugs, especially if you're doing generics, then you're in a more ripe area.
One other thing that I find interesting in Mark Cuban's way of thinking about this is he talks a lot about transparency, drug transparency bills. He's against opacity. He thinks it would be great if there were requirements for transparency for billing kind of across the board in all healthcare industries. And I think that he misses that it's one thing to have transparency for people to post their prices, and another thing for their prices to be truly based on some sort of market or value based system. The prices that we see across the board now are not related to the cost of anything. A surgery, the price for a surgery is not related to the cost to some, addition of the cost of supplies, the cost of nursing care, the cost of the doctor's time, the cost of the hospitalization in any way. It's a completely arbitrary number that's just chosen to be higher than all of those things. And so transparency is great and I am completely for it, but it is somewhat meaningless. And I think what we risk now with having these transparency laws is that places will just kind of they'll publish their prices, and then the prices will all sort of converge to one similar, still arbitrary price that will not be helpful in terms of shoppability for anyone. And so I think this is kind of just illustrates a little bit why the complexity is so much more, and the cultural kind of understanding of where prices come from and why we have them, and it is kind of missing from some of Mark Cuban's way of thinking about disruption in healthcare.
Isn't it interesting that with the recent breakup big medicine bill, which you two have both written about, Cuban has been in favor of that, right? Which is kind of interesting because he thinks of himself and puts himself out there as a fairly free market guy. That's kind of a contradiction there. Like I understand, he's been a critic of PBMs. This bill attacks them in a way, and so he's connected with it. But there's a sort of immediate thing that you can do to address some of these problems in healthcare policy wise. But it's often better to go down the chain a couple of steps and like find the thing that's further down the road that's maybe fixable, that sort of sets the whole thing in motion. If you could change that, then it would really change the environment. And that change that we might, posit being out there might not be something as kind of draconian as as the breakup big medicine bill. It might just be like a tax tweak, like as we've talked about, right? Like the something as simple as like the employer sponsored, the tax preference treatment of that employer sponsored care that has so many downstream effects. And changing something like that because you're looking multiple steps out, there are lots of good changes that could ripple out from that. And that's something that I wouldn't expect for Mark Cuban to be concerned about, because he's if the more focused he is on just the PBM issue, then he's going to be kind of, I guess, more receptive to policy proposals that are directly tied to that, as opposed to things that sort of are connected to it via a few steps. And so I guess that maybe that's understandable. I don't know. For us it's sort of frustrating because we like to look at the long term and the big picture, as well as specific policies as they come up. We're always looking to integrate things together like that. And maybe in the mind of a business related disruptor, he's looking more, I guess, immediate term possibly.
Yeah, I mean, if transparency is supposed to kind of capture a culture of open prices and shopping, a law by itself can't do that, right? I mean, like Colleen pointed out, you might just end up artificially posting prices, but it's not really like a market price where what's informing and driving that are the kinds of considerations that you would see in a market where you're thinking about value, cost, and competition and marketing to the people that are actually paying those prices. But what you can do is go after legislation that protects the kind of non-shopping mentality within the system, right? I'm sure there's all sorts of legislation that you could repeal that at the very least doesn't reward that. And you could come up with other kinds of reforms that encourage more of like a shopping kind of mentality. And so that even though it's not part of like the dominant culture yet, you're creating space for more of that to happen. And so the way that I see is that the most pessimistic outcome of Mark Cuban's efforts is that he'll disrupt the pharmacy benefit market and how we pay for prescriptions, and it'll just stop there, right? Like it won't change the rest of healthcare. Precisely because he doesn't really challenge the need for patients and providers to think of healthcare as being shoppable. But the best case scenario is that Mark Cuban is helping us create a kind of a beachhead where in the one area of healthcare where people might be more open to shopping, we can make it more normal and then be like, hey, why can't the rest of healthcare be like this? And look at the experience of people in this part of healthcare. Let's make the rest of healthcare more like buying drugs in the way that Mark Cuban has made possible. I definitely don't want to be too pessimistic of Mark Cuban. If anything, he's not being disruptive enough, right? He's disruptive only in the sense of like, oh, let's come up with a business model that challenges the powers that be. But to be really disruptive, you need to come up with a positive alternative, which I think he just takes that alternative for granted, but it's just not there in the rest of healthcare.
Yeah, again on disruption, sometimes you can imagine the thing that that you think that everybody's going to really want and love if you can deliver it to them, and then you create that, and and you in there was reason to believe that people were wanting it, right? And sometimes disruption comes out that way. Other times disruption is that somebody imagines something and people don't even realize that they would like it if they could experience it. And I mean, and there's all kinds of famous examples from like the business world, right? Isn't like Lee Iacocca and the Chrysler minivan was like a classic example of that, right? The thing I always hear from business students is that people didn't know that they wanted that, but Chrysler went ahead and put it on the market, and people fell in love with it, and now lots of families say, "Oh, I couldn't imagine life without it." Just that idea. It's like a new category of product, and there's a product disruption. Thing is, in car making, you don't have to go through the same policy hurdles as you do in healthcare, which is frustrating, right? You can just if you really want to take a gamble on a new idea, you can go ahead and do that, but you largely can't in healthcare. It's really frustrating.
Speaking of related industry, which I think is informative and which we've talked about in other episodes, are things like rideshare and Uber. That's an informative model because what happened there is that there were ambiguities about the law that companies like Uber, they launched these apps in particular cities, and then people love the experience. And then when people point out, like, hey, like, doesn't this violate taxi licensing laws? And then like, oh, we have to shut it down then. But then there was like a revolt, and like, no, we love this experience. And I think that model might very well work in the kind of uh, paying for drugs space. But I think right now, sadly, when it comes to the rest of healthcare, what we're seeing, it even if you had the space to come up with a new model, I think most people would say like, no, we need to protect the taxi licensing because, well, are you crazy? You're gonna like hop into a car with a complete stranger? That's the kind of attitude that I think pervades in most of the rest of healthcare. And unfortunately, that does mean that change there will be slower. But at the very least, if we can just make a few policy tweaks where people can at least launch like a different thing, where then people who are a little bit more adventurous can like try it out, well, then at least you can give it a fighting chance.
I mean, I think one major issue is that there are so many regulations that are not clear, and the risk to doctors and healthcare providers, hospitals, is so high that it's just it's years of training, years of your life, so much work and effort, and then to try something new that's maybe kind of in the between, and then someone comes and says, oh, what you're doing is actually fraud, and you thought it wasn't fraud. I think that risk is just so high that until we start to do things like actually allow doctors to practice in one context where they see Medicare and Medicare patients, and in another context where they clearly don't, um, or be a partial owner of a hospital and have a clear way of referring to someone else who's a partial owner of that hospital, making it clear to their patient that there is some interest there and that that's okay. You know, hospital systems that aren't owned by doctors do that all the time, and somehow that's fine. But if it's owned by a doctor, it's not okay to refer back to your hospital system if there's if you get something from the MRI that's there. I think these like little things, it's just so scary for doctors to try to do something new when you never know how that will be interpreted in the state of the regulations the way that they are now. It's different in every state. It's just so complex. They're just It's not worth losing your entire career over what you thought was a good thing, what you thought might be trying to offer something better or cheaper or nicer for patients, and then it turns out to be that you lose your license over it.
Right. Yeah. Because what's the like one of the scariest things that could happen to a doctor? You lose your license, right? I mean, it's. I mean,
Right.
you're afraid enough about the bad medical malpractice suit or something like that, or maybe or getting fired from your institution. But like those are at least fixable. My goodness. But like losing your license on something because we have this institution of licensing and everything.
Yeah.
So that has the effect of causing a lot of physicians in this case that we're talking about being very risk averse and conservative, not politically so, but I just mean not particularly willing to stick their necks out for something that is in operating in a legal gray area, right? Which is what
Yeah.
Uber was doing for a long time, right? I mean, Uber is such an interesting, and kind of fun case to contemplate. There were those there were many policy people who for years were writing about the silliness and craziness of the taxi medallion system, and coming up with ideas to reform it. And maybe you could argue this, or maybe you could gather this kind of evidence. And I'm not sure they ever really made headway in that particular issue. And it took somebody taking, I guess, because I don't know, were they well funded? Maybe it takes some money to like get that kind of alternative going, and you have to have a sort of critical mass in order for people to see that it's a viable alternative and everything. And then you have to be kind of fast enough to evade the legal consequences long enough until it becomes too politically costly for somebody to step in and actually shut you down, because now everybody in the city loves it, right? And so that just we can learn from that maybe, but is it exactly a translatable model? Maybe in some little pockets, like maybe a really good exercise is to like take a microscope out and look at the small little areas in healthcare where something like that could work. It's not going to be everywhere, I'll tell you that. But there might be some key places, and having discussions and having people help identify that, whether those are policy people or whether those are business people. I'd like to see more of cooperation and everything between policy people and business people.
And I definitely think an important factor is the kind of psychological conservatism of both doctors, but also patients, right? Like when it comes to your health, even if it's not like something very severe, people tend to just go with what's already out there. And I don't necessarily blame them either, right? But the real problem isn't necessarily being psychologically conservative about providing or consuming healthcare. It's about roping in the people who want to be disruptive and basically saying like, no, you have to be as conservative as the rest of us. What we're calling for is, hey, for those of us who want to be a little bit more adventurous, who want to try something new and even fail, like that's what progress looks like in the business world. That's what progress requires, is experimentation. Let us do that, right? Like you can operate in your system, but we would like to work with these innovators to try something new. And more broadly, that's kind of what I see as the purpose of this podcast and of our organization, as cultivating that kind of community between people in the policy world and in industry.
Yeah,
Yeah.
and I think you could also look at that as like a freedom, both for producers and innovators of healthcare and for patients to be able to freely choose what kind of system that they want to be in. We're not advocating taking anything away from anybody at this point. It's really more just opening up the playing field so that more innovation and creativity can happen for everyone.
Well, I think that's an excellent point to end on. And I would definitely call on those like Mark Cuban to continue being disruptive in healthcare, and hopefully with time a little bit more disruptive in challenging the status quo. And with that, I'd like to thank our audience, and till next time.
Thanks, everyone.
Thanks.
To stay up to date, subscribe to our show from whatever podcast platform you are listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.